Okay, so now we're going to start on musculoskeletal disorders, and we're going to talk about osteoporosis, fractures, and then osteomyelitis. We're going to talk a little bit about the pathophys, manifestations, care for the patient, and some medications. So there are some really good medication charts in your ATI review module book. And there's also some good images, but I think that most of it you can get from your Pellico book. But I will tell you that there's an excellent table about medications for osteoporosis in your ATI module, review module. Osteoporosis. Osteoporosis is a chronic metabolic bone disorder. And remember, when we talk about chronic disorders, they tend to be progressive, and there's little that you can do to reverse them. And what happens is the bone becomes less dense because of a problem with bone resorption, which means that the calcium is going back into the bloodstream and there's not as much bone formation. So calcium is leaving the bone, going into the bloodstream, and thus the bone is losing calcium. And that's an issue. Osteopenia is the precursor to this, and it means that it's a lower bone density when you compare it to other people of the same age, gender, and ethnicity. Ethnicity is definitely a risk factor for osteoporosis. Okay, so one of the things that happens with osteoporosis is the bones become very fragile, and even slight injuries and sometimes no trauma at all can lead to what we call a pathologic fracture. And a pathologic fracture means that it occurs when the trauma or the injury isn't expected to cause the damage. So sometimes this can show up as the fractures, compression fractures within the spine, and those are one of the ones that we most frequently think of as a pathologic fracture. Vertebrae just kind of fractures and then it impinges on the disc space and there's a problem. That's usually what we think about when we think about pathologic fractures. But because the bones are fragile, even slight trauma can cause a fracture. Okay, we already talked about the osteopenia. Now let's look at the risk factors for this. Risk factors include being female and white and over the age of 40. African American or Black women are much less likely to get osteoporosis. Women of Asian descent frequently have a problem with osteoporosis, though. Also, family history and a thin, lean body tend to increase risks for osteoporosis. Postmenopausal estrogen deficiency or decreased calcitonin can cause a problem with osteopenia and osteoporosis. Men who have a low testosterone can have an increased risk for osteoporosis. Low calcium intake, and there's not a lot that we can do about it once they're older because that happens in childhood or in adolescence when they have this low calcium intake. Or they have a decreased vitamin D problem, and that would impair calcium absorption. Okay, somebody who smokes or drinks excess caffeine. These three things in particular, in addition to carbonated beverages, tends to inhibit calcium absorption into the bone and increase calcium resorption, which is calcium going into the bloodstream. So that can cause a decrease in osteoblast activity, which is the formation of bone, and increase the activity of osteoclasts, which are releasing the calcium. Sedentary lifestyle or non-weight bearing, people who have paraplegia or quadriplegia, they have an increased risk for osteoporosis. Other things, secondary causes include hyperparathyroidism, where the parathyroid hormone, which pulls calcium, increases blood calcium, it's going to start sucking it out of the bone. So hyperparathyroidism can lead to osteoporosis. Steroid use, chronic steroid use for autoimmune disorders or asthma. Some medications used for seizure disorders like Dilantin or phenobarbital. And then, like I said, the problems associated with quadra or paraplegia. Now, this is a little visual aid to help you with the excess leads to osteoporosis. A is alcohol, C is corticosteroid or calcium low, estrogen, smoking, sedentary lifestyle. That's just a mnemonic to help you remember some of the risk factors. That's not all the risk factors, but that's a mnemonic to help you remember a lot of the risk factors. Health promotion. Now, remember I talked about when we were doing the diagnostic procedures that DEXA scan is a secondary level prevention. So when we talk about health promotion in osteoporosis, we're talking about primary or tertiary, preventing the development of osteoporosis or preventing further problems associated with it and slowing the progression. So of course you want to talk to them about their diet and things to increase in their diet, which of course would be milk and dairy, green vegetables, leafy green vegetables, fortified foods. Like when Rebecca was little, we gave her orange juice. She drank orange juice that was fortified with calcium. Also, beans have a high levels of calcium, and figs. Vitamin D is you can get vitamin D in fish, egg yolks, milk, of course, cereal. The best way to get it is to get out in the sunshine for 15 to 30 minutes a day where your skin actually is exposed to the sun, and limiting carbonated and caffeinated beverages. Another thing I want to mention is getting calcium from canned fish. Canned salmon, they tend to can it with the spine and the ribs intact. And when they're canned, the bones become very soft and they don't get stuck in your throat or cause problems with digestion. They're actually very, very soft. They're kind of the same consistency as just a little bit undercooked rice. So they can be a little bit crunchy. And so when I make salmon cakes at home, I leave the bones in because they're a very good source of calcium and they don't cause any problems. All right, so I talked about the 15 to 30 minutes of sunshine on the skin. On the skin, it has to be on the skin so the vitamin D can be absorbed. And the weight-bearing exercises. We want to encourage people to walk. That's one of the best weight-bearing exercises is to walk because they're bearing their own weight. But that doesn't work in the water. Doing water aerobics or water jogging isn't a weight-bearing exercise because it just doesn't give enough pressure. So weight-bearing exercises such as walking, the elliptical can be considered weight-bearing exercise, and then lifting weights is weight-bearing exercise. And that drives calcium back into the bone, so that's a good thing to do. Hormone replacement, hormone replacement's kind of questionable. Of course, if you're estrogen depleted or testosterone depleted, then that increases the loss of calcium from the bones. But taking hormones has its own problems. It increases risk for DVTs and for certain types of cancers. So you just can't willy-nilly say, oh yeah, you need estrogen replacement. It kind of depends on their family history and their risk factors for vascular disease and for cancers, especially breast and uterine cancer. Here's a picture of some of the things, just another kind of visual for you to think about where's calcium located. If you see down there in the middle, it says sardines. They can sardines whole. You eat them whole. You don't try to get the bones out of them. So that's the same way we eat our canned salmon at home. Manifestations, they have a loss of height. Acute back pain. Acute back pain can be indicative of a fracture in the spine. Restriction in movement or spinal deformity. A history of fractures, especially where the injury or the trauma doesn't seem like it should actually cause a fracture. Kyphosis. If you look at the woman there on the far right, she's got kyphosis, and if you look very closely at the vertebrae, you'll see that they're small, and those are very small compression fractures. And then also pain when you palpate the area where it's affected. Like if you palpated her the thoracic spine in this lady here in this picture, it would be painful to the touch. Laboratory tests, you want to check the serum calcium, vitamin D. They would check the phosphorus because calcium and phosphorus levels are intimately linked like sodium and potassium levels are. And then you would also check an alkaline phosphatase level. I know that is a liver enzyme, but An elevated alk phos can be indicative of Paget's disease as opposed to osteoporosis. So you would check that to rule out some other cause of the porous bones. All right, and then thyroid tests and serum protein, of course, to rule out thyroid disease because there's a hormone produced in the thyroid, calcitonin, that is one of those controllers of calcium levels. And so if you have a depletion in the thyroid hormone calcitonin, then there could be a problem with demineralization of the bones, which leads to osteoporosis. Okay, so those are some of the tests. And of course, then we talked about the DEXA scanning. That's a screening. Also, x-rays. Sometimes on x-rays, you can actually see that the bones are less dense and fractures. And then CT scans, especially the lumbar and thoracic spines, to visualize fractures in the spine. Medical management includes medications. We're going to talk about that. Supplements of vitamin D and calcium, physical therapy and exercises to increase or improve weight-bearing exercises. There are braces if somebody has a problem with the vertebral fractures. They have a kind of a vest or a upper body kind of splint that they can wear that needs to be fitted and placed by PT, and PT needs to teach the patient how to use it. But that is to alleviate pressure and pain. And they, of course, need to be taught to check for pressure, skin changes, and things like that, potential complications related to wearing this brace for long periods of time. Then surgical interventions include a joint repair or replacement, arthroplasty, and then vertebroplasty or kyphoplasty. And that's what the picture is here on the right on this slide, is you can have, these are kyphoplasties where they go in and they fill the joint with a somewhat springy, it's not all that stiff. It has some give to it, kind of like when you see a building that's built to withstand hurricanes. You know, it can shake a little bit and it'll be okay. When you do a kyphoplasty or vertebroplasty, that's the same thing. You're filling the joint with something that can be, that's a little bit movable and isn't going to fracture with types of movement. Complications of osteoporosis, one of the most frequent ones we see is hip fractures and the vertebral fractures, and also wrist fractures because people stick their arms out to hold to catch themselves when they fall. And hip fractures, most of the time, if somebody gets a hip fracture and they're over the age of 60, there is some osteoporosis that's present. Patient education and nursing implications. I have links here for you if you're looking at the regular PowerPoints, but you need to talk to your patient about medications, diet, supplements, what are weight-bearing exercises, and then home safety. You know, we talk about removing rugs, wearing the correct kind of shoes, watching out for pets that get underfoot, using their assistive devices, using a walker, using a cane. Don't use the furniture. That kind of, teaching the patient that kind of stuff. And then threshold. At my parents' house, before they moved out, we put bright yellow tape on a ledge that both of them frequently missed. Even though they'd lived there 30-something years, we put some bright yellow tape like you see on the road sometimes, so that they would see, so it would reflect and they could see that edge so they wouldn't trip over it. But making their house safe and encouraging the use of the assistive devices is really important for people to help prevent falls. All right, the medications, there is an excellent table in your book. I've mentioned this a couple of times. It starts on page 780. It's just 780, 781, and it talks about medications that we use to treat osteoporosis. One of the most frequent ones we talk about is bisphosphonates. And what that does is it inhibits bone reabsorption. Of course, there's a lot of them. I want you to know the class. Bisphosphonates. It inhibits bone reabsorption by preventing osteoclast activity. Now remember, osteoclast activity sends calcium out into the blood. So by inhibiting that, the calcium stays in the bone. Of course, here's some of the side effects. Acid reflux and esophageal ulceration. So this is the type of medication that you want to tell them that they have to sit up for a while after they take it, right? You want them taken on an empty stomach, and you want them to sit up for at least 30 minutes after taking. But other side effects include headache, constipation, hypocalcemia, and hypophosphatemia because it's not allowing that stuff to go into the bone. So if the patient doesn't have enough intake of calcium and phosphorus, then they're going to have a decreased serum calcium or phosphorus. So you need to do some patient teaching about diet to prevent that. That's assess calcium and phosphate, not phosphate or phosphorus. Take middle on an empty stomach and remain 30 minutes upright. Now, estrogen receptor modules, these are medications that work they mimic what estrogen does without actually being estrogen. They actually are used frequently to treat breast cancer. So they reduce resorption, meaning moving of calcium from the bone into the blood and prevent bone turnover. Because these are estrogen-like drugs or produce the same effect as estrogen, you need to be careful for some of the same side effects. Anything to do with embolus or clot formation. Okay, problems with estrogen like hot flashes, bleeding, uterine malignancies. Although these are used for breast cancers that are sensitive to estrogen, they can increase the risk for uterine malignancies. Educate the patient for signs and symptoms of DVT. Monitor the labs and tell the patients to make sure they report bone pains. Okay, and then of course calcitonin. This is just taking a calcitonin replacement, and it acts in the same way that calcitonin that's produced by the thyroid does. It increases bone density by decreasing the movement of calcium into the bloodstream. Because it's taken into the nose, it can cause nose pain. People have actually gotten calcification in their nair. What they actually do is they alternate one nostril to the other. Okay, and I think it's like once a week medication. And then you also alternate between nostrils because you don't want to cause the damage in the nose. So nasal irritation, altered taste goes with that. It can cause back pain and facial flushing. Patient education, if they're allergic to fish, because it is an exogenous fake, it's actually fish calcitonin. Okay, so if they're allergic to fish, they can't take it. They need to increase their calcium intake, and you need to monitor them for hypocalcemia. Okay. All right, so now we're going to talk about fractures. I think this is probably one of the longest sections that we have in here is fractures, because there's so many things that can happen with fractures and different interventions that we do and potential complications. Right, so fractures are a break in the bone, usually due to trauma like a football injury or a car accident or a fall, something like that, or it can be related to a pathology, something like cancer. If you have bone cancer, those areas are usually very easily fractured. Osteoporosis or Paget's disease. Paget's disease is another type of metabolic bone disease. It's fairly rare, but it causes extreme demineralization of the bone, and they can actually have holes in there. I mean, not just decreased density, but holes in their bones. Health promotion, when you look at fractures, you need to tell the people ways to prevent it, like is decreasing their risk, making sure that they wear their seat belts, and if they engage in activities such as biking or rollerblading, whatever, whitewater rafting, they need to make sure that they wear their helmets and that they are seat belts in the car, falls prevention, and then monitor for how can they monitor themselves for osteoporosis, right? When we're talking about fractures, there are some risk factors associated with it. Of course, there's osteoporosis, okay, falls, motor vehicle crashes, substance use disorders. People who drink or who use drugs are more likely to fall and also to have problems with malnutrition, which would increase their risk for fractures. Contact sports and things like ice skating, snow skiing, snowboarding, those kinds of things. Being in a physically abusive relationship, lactose intolerance, and increasing age. Let's talk a little bit about the types of fractures. You can have a closed simple fracture, and all that means is it's just one or two bones that are broken. Like you can have a tib-fib fracture that's a closed simple fracture. That just means that it's not displaced. There's not a whole bunch of little pieces. It's not skin defect or laceration that's associated with it. You can have an open fracture where the bone is actually, if you look on the far right there, just before the vertebral compression fracture, that's a compound or open fracture, excuse me, where the bone is actually sticking through the skin. That's a problem, okay, because that increases risk for infection and other complications. You can have a complete or an incomplete where the bone is broken all the way through or not broken all the way through. That green stick fracture in the first one, the green stick fracture is an incomplete fracture. The transverse fracture is a complete fracture. That's a complete fracture. Now you can also have a displaced fracture. That compound fracture is a displaced fracture. And you can have a stress fracture, which tends to be long, lengthwise along the bone as opposed to crossways, and it tends to be an incomplete fracture. And then also a compression fracture. Okay, we're going to talk a little bit more about some of these. I just talked about all these risk factors for fractures. The one thing I didn't talk about is the long-term corticosteroid use. Also, I want you to think about people who just are on medications that may increase their risk for falls. Antihypertensive medications, they can have that. Orthostatic hypotension, people who are on medications for pain, like narcotics, can have or increased risk for fractures because they can fall more frequently. Okay, so those are some of the risk factors. All right, now manifestations of risk factors. First off, usually there's a history of trauma where they had some kind of injury. It's not like, or they have a metabolic bone disorder, or they have a fracture. Usually there's pain. A lot of times there'll be a point pain where you can touch them in a certain place and it really hurts there. And they can have reduced movement. In general, though, people can still move it, at least passively, even with a fracture. On physical assessment, you'll hear crepitus, that's the bone joints rubbing together. Okay. Deformity, if you look at this hand right here, or this wrist, you can tell there's a deformity there. I mean, it's not supposed to look like that. That kind of looks like Harry Potter's hand in Chamber of Secrets. That's what Harry Potter's hand looked like after that guy tried to fix it. Muscle spasms, seen frequently in fractures. Edema, of course, swelling, bruising, redness. A lot of people actually get nauseous and they vomit after a fracture. And I'm not quite sure why that is, but that is not uncommon with fractures, nausea and vomiting. Diagnostics, in general, we look at x-rays. You can see here, the first x-ray there on the left is that's considered a fractured hip. Even though it's right there in the femur, they'll say that's a fractured hip, and that's because it's right there below the greater trochanter. And so that's a problem. This is a wrist fracture. This is a complicated fracture. One, because you have this complete fracture in the bone. But then the other thing is you have a displacement. So the ulna is fractured and the radius is displaced. It's like the ulna is fractured and the radius is displaced. So that's kind of a complicated fracture. Not a comminuted fracture, but a complicated fracture. That's a view. I think that might be a view of the same wrist there, the third one. And the fourth one, I'm looking at this fourth one, and I can't tell what that is because it doesn't look like a tib-fib fracture, like if that was the knee, but it also doesn't look like there's two bones, like if it was a radial and an ulnar fracture. But that's a comminuted fracture. You can see that there's a lot of different pieces and stuff like that. I have no idea what that is. Those are how some fractures look on x-rays. So medical management, one of the first things you want to do is immobilize it. We immobilize them with splints or with casts or with traction. Those are the main ways to immobilize fracture. And that is, the reasons we do that is to, of course, prevent further injury. You don't want that bone coming out of the skin or tearing up the muscles inside. It actually promotes healing and circulation. If it's immobile, it will heal better. It won't wiggle back and forth. It reduces pain and it can correct the deformity. If you don't put the bones in alignment, then there'll be a permanent deformity. The types of immobilizers include casts, which we're most familiar with, and they can be plaster or the fiberglass, splints and other immobilizers. Traction is a type of immobilizer. External fixation, and I'll show you pictures of external fixation and also internal fixation. What they call a reduction, where they're putting the bones back in alignment. And you can have a closed reduction where you manually pull the limb or whatever to realign the bones. We see that a lot. And an open reduction is when they open up the area and realign the bones. A lot of times an open reduction will involve plating or screws or something like that to hold the bone in place. And that's usually done when there's comminuted or complicated fracture. So casting, I talked about the plaster of Paris or synthetic fiberglass. What's here on the right side of the screen is moleskin, and it's very soft, and they usually puddle the edges of a cast with that so that there's no rough edges to rub against the skin. Now, casts are not applied until after swelling goes down because they don't want to instigate a compartment syndrome. Cast can be split, that's called bivalving, where the cast is just cut down on each side, kind of like a turtle shell. Also, there can be windows in it so that you can see if there's a wound or a problem there. First, you don't put casts on until after the swelling goes down. And then there's neurovascular checks and monitoring for pain. They can use ice for 24 hours, and that can be done on the outside of the cast, and it does radiate in. That helps decrease the edema and also helps decrease pain. And they should elevate that limb above the heart for 24 to 48 hours to prevent edema and complications associated with compartment syndrome. Right after casting, it's really important to handle the cast with care so that you don't squeeze it and cause pressure. So you lift cast with the palms, even if it's fiberglass. Fiberglass dries a lot faster than plaster casts do, but you always want to lift it with your palms and not your fingertips. And you don't want to set the cast on an edge or on a sharp surface, a hard surface, while it's still wet before it's completely dried, because then it can cause some problems with pressure on the limb itself. Casting, patient education. You gotta tell patients not to stick stuff down in their cast, even if they can't put stuff down their cast. Use a plastic covering if they're gonna get wet or to get showers. Report hot spots or painful areas, and report bad odors. Not just BO because you had this cast on, but report odors because that could be an infection or problem associated with that. All right, traction. We use traction to promote and maintain alignment, but the other thing that it's good for is that it really helps decrease muscle spasms. And a lot of times we'll put people in traction for 24 hours to 48 hours before they have surgery, so the muscle spasms have decreased and the bones have realigned or come back into more alignment. It does decrease pain, and it does help prevent further deformities. All right, there's two kinds of tractions that we use most frequently. We use Buck's traction, which is the one on the left there, or skeletal traction, where there's actually a hole drilled into the bone there. And both of these types of tractions are for femur or hip fractures because they will help prevent muscle spasms and pain and promote alignment. So traction nursing care, you got to look at the 5 Ps. You guys need to know these 5 Ps. These are indicative of neurovascular compromise. And it's pain. You want to check for pulse. There'll usually be a decreased pulse, pallor, paralysis, and paresthesias. All those are indicators that there's a problem with neurovascular compromise. Other things you need help with is body alignment. You want to make sure that they don't have problems with their upper body alignment. You can kind of shift them from side to side up top, but really they have to stay with their legs straight. And you want to keep their body in alignment, maintaining the position of the leg. You need to make sure that the ropes and the weights hang free, or else there's not really any traction. Checking skin integrity. If it's a skeletal traction, checking the pin sites. And for the bucks traction, checking the skin to make sure that it's not being damaged underneath the wrap. Treating pain and range of motion with the other extremities. And it doesn't have to be passive range of motion. They need to do as much, the patient needs to do as much active range of motion as possible. Of course, I already said something about the pin care. You want to monitor for drainage and redness. Some serous drainage is normal, but if it's pussy or it becomes bloody, that's a problem. Also, look in the skin around the pins. Increasing redness or edema can be indicative of a problem, as can tenting of the skin around the pin. That could mean that the pin is becoming loose and pulling at the skin. Now, you clean around the pins according to facility policy. Usually there's one Q-tip for each pin, and you do it 1 or 2 times a day or every shift. If there's crusting and it's from serous drainage, it shouldn't be removed because it's protecting the hole and it's preventing infection from getting in. The surgical interventions include internal fixation. That's there on the left. That's a radial ulna fracture. And it looks like it's a comminuted fracture there. The radius looks like there's a comminuted fracture. And then they've plated both bones with screws, and you can see that. Now, the one on the right side is an external fixator, and I'm thinking that this guy here must have had some serious fracture. He landed, maybe parachuted, and then didn't land correctly. And he had like this compression kind of fracture on his leg. I'd like to see the x-ray for that. But one of the things about internal and external fixation is it increases early mobility because they're plated and they're usually given like a sling or something to help support that patient comfort, and they can do more active exercise. And I'm thinking, that doesn't necessarily apply to this guy on the right, but the person on the left definitely can decreases the time frame which they can start being active. Internal fixation, open reduction internal fixation used to treat complicated fractures that wouldn't heal with just using a cast. Wound care, because they've gone in and surgically, they've usually used an incision. You'll have to provide wound care and dressing changes. There'll be suture line care, pain control, not just from the surgical incision, but also from the fracture. Your job is to prevent complications associated with post-op period and things that occur preoperatively and perioperatively, and patient education. What they can do, what their activity level is. They'll need to be able to redress their wounds and to clean the wounds when they go home, when to come back and see the doctor to have sutures removed and that kind of thing. Now, external fixators are used frequently when there's an open fracture and, of course, with complications. Now, I want you to look at these 3 pin sites here. If you look at the very bottom pin site, that doesn't look infected at all. Okay, but if you look at the middle pin site, there's some erythema around there, and it kind of, there's some concern there. But if you look at that top pin site, you can tell that is infected. Okay, there seems to be some drainage around it, and it's very red, and you can see that the skin is pulling away from the pin. That's indicative of an infection. With external fixation, again, pain, pin care, that's according to facility policy. Wound care, because it's most frequently done on complicated open fractures and preventing complications. Patient teaching involves pin care, preventing infection, and use of assistive devices, such as crutches, slings, and that kind of stuff. They need to know how to use that. All right, hip fractures are a special case of fracture, and at least 250,000 people are hospitalized annually. And 95% of hip fractures are caused by falling sideways. Of course, most of these people also are women who have a history of osteoporosis. And as you go up, as you get older, the risk of having a hip fracture increases. And 30% of people who have a hip fracture will die within a year. Usually complications associated with it, like pneumonia or problems associated with immobility, or because they had an underlying disease process and did not have the reserve, the physical reserve, to recover from a hip fracture. Manifestations, of course, there's pain with increased movement, and the affected leg can be shortened and rotated. Now, rotated in or rotated out depending on displacement of it, but if you look here, you can tell that this person's left leg is shorter than the right, and it's rotated outward. And of course, like I said, most hip fractures are related to falling sideways from a standing position or when somebody's standing up. These are the type of hip fractures that can occur. One of the ones that we most frequently see is the subtrochanteric fracture, which is the bottom left, or the intratrochanteric fracture, which is the top right. Those are some of the kinds of fractures that you can see. Now, medical management of hip fractures usually involves a surgical repair with either screws or plating or replacement. They're usually put into temporary traction because in hip fractures, there's frequently a problem with really bad muscle spasms. Those have to go away before you can go in there and do the surgery. There's usually temporary bucks traction. And these are some of the ways that they do the repairs. Screws, plates and screws, or they can do a hemiarthroplasty where they replace half the joint. Pre-op, of course, there's a traction. You need to do lots of neurovascular checks. They're positioned in bed using a wedge. That helps prevent the rotation or further displacement. Pain control and patient education about what's happening and positioning and stuff. Okay? People who have hip fractures should no longer ever cross their legs. Ever cross their legs. Post-op, maintaining position and pain control and preventing complications. Once patients who've had a hip fracture can get up and get in a chair, they need to make sure that they have a wedge to prevent their knees from coming together, and this will also help decrease the risk of them crossing their legs. People who've had hip fractures and hip fracture repair are much higher risk for DVT than most other types of surgeries, except for abdominal surgeries. There's frequently a problem with UTIs and incontinence associated with the use of Foley catheters during the surgery. A lot of times age can add to this, and problems with incontinence because it's difficult to get on a bedpan and they don't, want to get up. Pneumonia is a problem. Neurovascular complications. Avascular necrosis, where if you have a complete fracture there and they're older and they have decreased perfusion or they already have vascular disease, they can develop avascular necrosis, which is a necrosis of the bone from lack of circulation. Heart failure, because the heart has to work really hard. Constipation from immobility and pain meds. And of course, infection. And here's a little picture for you for hip fracture, things that we do, treatment, and then the risk factors, and then nursing priorities. And it's just a way for you to remember this. Now, I'm going to stop here and upload this video. I don't want the video to get too long, and then we'll start with some complications of fractures.